Let me ask you something. What if the moment someone you love disappeared into dementia, the dementia wasn't actually there? What if the confusion, the blank stare, the person who stopped recognizing you, was their body sending a distress signal that everyone in that room missed? Not slow deterioration, a medical emergency, treatable, reversible, gone within 24 hours if someone had caught it in time. I'm a neurologist. I've watched this happen. Watched the wrong conclusion get written into a patient's chart. Watched a family grieve someone who was still there. More times than I'm comfortable telling you. There's a specific mistake that happens at this exact moment. So common, it has a name inside geriatric medicine. And it almost certainly happened to someone you love, or it's about to. Stay with me. By the end of this video, you'll know exactly what that mistake is, how to spot the warning signs before the window closes, and what the first 24 hours have to do with whether someone gets their mind back. My name is Dr. Amanda Carson, 2 decades in neurology, sitting across from families in rooms where the news was never easy, reviewing scans, trying to answer the question no family member should ever have to ask. Is this permanent? I've watched patients walk out of hospital wards with their full cognition restored after being told by well-meaning colleagues that what they were seeing was the beginning of the end. And I've watched the opposite. Reversible conditions labeled irreversible, treatment withheld, families beginning to grieve someone who was still cognitively intact, underneath a crisis that had a name, a cause, and a cure. I'm not here to tell you dementia isn't real. It is. It's one of the most devastating diagnoses in medicine. I'm here to tell you this. Not every cognitive collapse that looks like dementia is dementia. And that difference, reversible crisis versus irreversible disease, can be determined, but only if someone asks the right questions in time. Here's what I've spent 20 years watching people get wrong. When an elderly person has a sudden dramatic mental shift, confusion, disorientation, personality changes, not recognizing family, the clinical instinct is to reach for the most available explanation. In an elderly patient, that explanation is almost always the same word: dementia. It goes on the chart. It shapes every care decision that follows. And in a significant number of those cases the data now documents with uncomfortable clarity, that word is wrong. Not slightly wrong. Wrong in a way that left a treatable condition untreated. Wrong in a way that let the underlying cause keep damaging the brain while everyone accepted the damage as done. Wrong in a way that, past a certain point, makes reversal impossible. This isn't fringe research. It comes from peer-reviewed geriatric and neurology literature, and it describes a pattern of diagnostic error reaching into virtually every clinical setting where elderly patients receive care. That pattern has a name. It starts with a belief so reasonable, so completely understandable, that almost no one stops to question it, until now. Here is what we have always been told. When an elderly person's mind begins to fail, when they become confused, when they stop recognizing faces, when they say things that don't make sense, when they seem to disappear from behind their own eyes, that is what aging looks like at its most advanced stage. We have been taught that the brain, like any organ, simply wears out, that cognitive decline in the elderly is a one-way road, that when the confusion comes on strongly enough, clearly enough, visibly enough, it means the disease has progressed to a point where the person you knew is no longer fully accessible. And here's why that belief makes complete sense. We have watched it happen. Most of us have a reference point, a grandparent, a parent, a neighbor, whose decline followed exactly that arc. Gradual at first, then more noticeable, then one day a crisis point where something shifted and never fully came back. The pattern is familiar. It is embedded in how we talk about aging. It is embedded in how medicine has historically talked about aging. So when it happens, when you get the call or you walk into the room and something is profoundly wrong, the mind goes immediately to the explanation that the pattern has always pointed to. This is the dementia getting worse. It makes sense. It fits the age. It fits the history. It fits every story you have ever heard about what this stage of life can look like. And there is something else that makes this belief feel even more solid. The symptoms themselves are convincing. A person who cannot tell you what year it is, a person who doesn't recognize their own children, a person who is agitated or completely withdrawn, or saying things that have no connection to reality. Those are not subtle signs. Those are not easy to dismiss or second guess. When you are standing in front of someone experiencing that level of cognitive collapse, the idea that it might not be what it looks like, that it might be temporary, does not feel like a reasonable possibility. It feels almost cruel to suggest it, because if it might be temporary, then every moment you spend accepting it as permanent is a moment you are not fighting for them. That is an unbearable thought. So the mind protects itself by accepting the more available explanation. This is the disease. This is where we are now. This is what comes next. Clinicians do the same thing, not out of negligence, out of pattern recognition that has been reinforced thousands of times. An elderly patient, sudden severe confusion, the history of cognitive fragility. The chart practically writes itself. That belief, that sudden cognitive collapse in an elderly person means the dementia has progressed, is one of the most consequential assumptions in modern geriatric care. And in a specific, critical, measurable percentage of cases, it is wrong. To understand why that assumption is wrong, you need to understand what is actually happening inside the brain when an elderly person collapses cognitively, not over years, but over hours. The aging brain is not simply a younger brain that has slowed down. It is a brain operating with significantly reduced reserve. As we age, the brain undergoes measurable physiological changes: decreased blood flow, reduced neuronal density, lower levels of the neurotransmitters responsible for attention and memory. These changes do not automatically produce dementia, but they do something equally important. They lower the threshold. Think of it this way. A young, healthy brain has an enormous buffer against external insults: infections, dehydration, medication changes, metabolic disruptions. That buffer absorbs the shock. The person may feel unwell, they may be fatigued, but their cognition remains largely intact because the brain has enough reserve to compensate. In an elderly brain, that buffer has been significantly depleted. The margin between functioning and failure is razor thin, and when a physiological stressor arrives, even one that would register as minor in a younger person, it does not get absorbed. It triggers a collapse. Here is the specific chain of events. When the body detects an infection, a urinary tract infection, a chest infection, even a wound, the immune system launches its response. It begins producing pro-inflammatory signaling proteins called cytokines, interleukin 6, interleukin 1, tumor necrosis factor alpha. These are the body's alarm chemicals, and in a healthy immune response, they do exactly what they are supposed to do. They mobilize the defense system against the threat. But in an elderly patient, those same cytokines do something additional, something that does not happen to the same degree in younger adults. They attack the blood-brain barrier. The blood-brain barrier is the brain's protective interface, the structure that separates the neural environment from the rest of the body's circulatory system. In the aging brain, this barrier is already more vulnerable. Pre-existing vascular fragility means the endothelial cells holding it together are not as resilient as they once were. When the cytokine surge arrives, it begins to degrade those cell-to-cell adhesions. Interleukin 2 specifically has been identified as a direct mediator of blood-brain barrier breakdown. As the barrier's integrity fails, the permeability increases, and what was designed to stay outside the brain, inflammatory mediators, immune cells, systemic chemical signals, begins crossing into the central nervous system. The moment that happens, the brain's own immune cells, the microglia, activate. In a healthy brain, microglia perform essential maintenance, pruning synapses, clearing debris, monitoring for threats. But under the conditions of acute systemic inflammation breaching the barrier, they shift into a hyperreactive state. They begin releasing neurotoxic substances, reactive oxygen species that damage neural tissue, excess glutamate that overstimulates and destabilizes neurons, further inflammatory signals that compound the damage. The coordinated neural network activity that produces clear thought, sustained attention, and orientation to reality begins to disintegrate. Not because the neurons are dying in the way they die in Alzheimer's disease, because the environment they operate in has been chemically overwhelmed. That is the mechanism. That is what a urinary tract infection looks like inside an elderly brain. So when you walk into that room and the person you love doesn't recognize you, agitated, absent, saying things disconnected from reality, here's what you now know that almost no one else in that room understands. That is not the dementia advancing. That is a brain failing to maintain function under a chemical siege it was never equipped to withstand alone. The confusion isn't evidence the mind is gone. The confusion is the symptom. It's the brain's alarm system firing at maximum volume because something is wrong in the body, and the body has no other way to tell you. This distinction is everything, because one explanation ends the conversation. The other opens a window. That window has a name inside geriatric medicine: delirium. And the critical word attached to it, the word that changes every decision that follows, is this one: reversible. Delirium is not dementia. It is not a stage of dementia. It is acute brain failure, the brain's equivalent of what happens to the kidneys in acute renal failure, or the heart in acute cardiac failure. A temporary collapse of function driven by a treatable external cause. Here's the number that should stop you cold. Up to 60% of delirium cases are missed by the primary clinicians who see those patients. Not questioned and reconsidered, missed entirely. Up to 13% of all dementia diagnoses are incorrect. In certain clinical populations, that error rate climbs to 30%. Post-mortem studies have found that 25% of confirmed Alzheimer's diagnoses didn't hold up under autopsy. The neurodegeneration simply wasn't there at the level the diagnosis required. Let me tell you about a patient I will call Margaret. Margaret was 79 years old, retired school teacher, sharp, independent, the kind of woman who did the crossword every morning and still corrected people's grammar at the dinner table. She had mild, documented cognitive decline, early-stage memory softening that her family had been monitoring for about 2 years. Nothing dramatic, nothing that had changed her daily life in any significant way. One Thursday evening, her daughter came to visit and found her unrecognizable. Margaret did not know what year it was. She did not know she was in her own home. She was agitated in a way her daughter had never seen, accusatory, frightened, pulling at her clothing. Within the space of a single afternoon, the woman who had been managing her own household independently had become someone her family did not recognize. Her daughter did what most families do. She called an ambulance. And the clinical team that assessed Margaret did what clinical teams, under time pressure, with an elderly patient and a documented cognitive history, very often do. They attributed it to her dementia. The family was told this was likely progression. They were advised to begin considering care arrangements. No one ordered a urinalysis that night. When one was eventually run, 26 hours later, the result was unambiguous. Margaret had a severe urinary tract infection. No fever, no pain on urination, no classic symptoms whatsoever. Just a brain, already operating with reduced reserve, chemically overwhelmed by a systemic infection her body had been quietly fighting for days. She was treated with a course of antibiotics. Within 72 hours, she was doing the crossword again. The care arrangements her family had begun researching were never needed. The progression that had seemed so sudden and so final was not progression at all. It was a missed infection, a missed diagnosis, and very nearly a missed life. Margaret's story did not require a specialist. It did not require advanced imaging or a neurology consult or any intervention that was unavailable to the team that saw her on that Thursday evening. It required one question asked in time. What if this isn't the dementia? That question and the investigative steps that follow from it is what I want to leave you with. Because the protocol that catches the 24-hour reversible mistake is not complicated. It is not expensive, but it has to be initiated deliberately, and it has to be initiated fast, because the window is real and it closes. Here is what that protocol looks like in practice. Step 1. Establish the baseline. The first and most important step is to establish a baseline. Before any clinical assessment means anything, the medical team needs to know what this person's cognition looked like 1 week ago. Not 1 year ago, not at their last scheduled appointment, last week. Was this person orienting normally to their surroundings? Were they managing their daily routine? Were they recognizably themselves? This is information that does not exist in a chart. It exists with the family, which means the family's voice in that room is not supplementary. It is diagnostically essential. If you are the family member, you are the most important person in that assessment. Insist on being heard. Step 2, the rule-out protocol. The second step is the rule-out protocol. Before any cognitive collapse in an elderly patient gets attributed to dementia progression, 4 investigations need to happen, and they need to happen urgently. A urinalysis and urine culture. Urinary tract infections are the single most common reversible cause of acute cognitive collapse in elderly patients, and in this population they frequently present without fever, without pain, without any of the classic symptoms that would normally trigger suspicion. The only way to find them is to look. A blood panel. Thyroid function, vitamin B12 levels, electrolytes, blood glucose, and inflammatory markers including C-reactive protein. Each of these, when dysregulated, is capable of producing cognitive symptoms that are clinically indistinguishable from dementia progression. An extreme TSH reading, thyroid hormone levels dramatically out of range, can alone produce a presentation so severe it has been mistaken for end-stage neurological disease. A B12 deficiency impairs the very neurotransmitter pathways that underpin memory and attention. These are not obscure findings. They show up on a standard blood draw. A medication review. Any new drug introduced in the preceding weeks, any dose adjustment, any addition to an existing regimen needs to be examined. Medications with anticholinergic properties, and there are many, including common antihistamines, bladder medications, and certain antidepressants, directly suppress the neurotransmitter systems responsible for attention and memory. In an elderly brain already operating with depleted acetylcholine reserves, a single new anticholinergic medication can produce profound dementia-mimicking cognitive impairment within days. Step 3. The CAM assessment. And finally, a clinical assessment using the right tool, not a general memory test. The confusion assessment method, the CAM, is the validated clinical instrument designed specifically to identify delirium by detecting its defining features: acute onset, fluctuating course, inattention, and disorganized thinking. It takes minutes to administer. Its sensitivity for detecting delirium exceeds 90%, and it asks fundamentally different questions than a standard cognitive screen, because it is looking for a different condition. If you are advocating for someone in a clinical setting, these are the 4 things you ask for by name: urinalysis, blood panel, medication review, CAM assessment, not as requests, as requirements. The 24-hour window is not a metaphor. It is a clinical reality. Delirium that is identified and treated promptly resolves. Delirium that is missed and allowed to persist causes cumulative neurological damage. Each hour of untreated acute brain failure accelerating the very cognitive erosion that everyone assumed was already happening. The reversible mistake becomes irreversible, not because it had to, but because no one asked the question in time. You now know the question. We were told that when an elderly person's mind collapses suddenly and severely, it means the disease has progressed, that the person we knew has moved further away, that the appropriate response is to adjust our expectations and begin preparing for what comes next. That belief was not careless. It was not the result of negligence or indifference. It was the logical conclusion of a pattern we had been shown, and a medical framework that for too long treated the aging brain as a passive victim of inevitable decline, rather than a dynamic organ capable of crisis, recovery, and rescue. But now you know what that collapse actually is. You know that a urinary tract infection can breach the blood-brain barrier of an elderly patient with no fever, no pain, and no outward sign of infection, and produce a cognitive presentation so severe that it fills every clinical checkbox for advanced dementia. You know that inflammatory cytokines like IL-6 have been measured at 10 times their normal upper limit in patients experiencing delirium. You know that the microglia, the brain's own immune cells, can turn neurotoxic under systemic inflammatory pressure. You know that the blood-brain barrier, already fragile in the aging brain, can be directly compromised by a single signaling protein, interleukin-2, released in response to an infection happening nowhere near the brain itself. You know that up to 60% of these episodes are missed, that the misdiagnosis rate for dementia reaches 30% in complex clinical populations, that 25% of Alzheimer's diagnoses have failed post-mortem confirmation, and you know that the window to reverse it is 24 hours. The body is not failing in the way we were taught to expect. It is failing silently, systemically, in a way that wears the face of something permanent, when the cause is often something as treatable as a bacterial infection identified on a 2-minute urine test. That changes everything about what you do the moment someone you love stops being themselves. You do not accept the first explanation. You ask what changed in the last 24 hours. You request the rule-out protocol. You treat the brain as an organ in crisis, because that is exactly what it is. Margaret got her crossword back. Not every family gets that outcome, but far more of them could if someone in that room knew what you now know. Share this with someone who needs it before the morning it matters.